Good afternoon, everyone, and welcome to today's webinar discussing weight control in Black men, context, challenges, and intervention considerations. I would like to thank you all on behalf of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, ACORN, and the Center for Diabetes Translation and Research at Washington University, St. Louis, for your participation this afternoon and interest in this topic. During the presentation today, we ask that you pose questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to use the chat window to interact with fellow attendees during the session this afternoon. This presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. My name is Sheldon Oliver Watts, and I am the National Director for the Council on Black Health, also known as the Council. The Council is the new identity for the African American Collaborative Obesity Research Network, a collaborative network of scholars and community-based research partners located in over 20 different states. The Council's mission is to develop and promote solutions that achieve healthy Black communities. Our national office is located at Drexel University's Dornsife School of Public Health in Philadelphia, Pennsylvania. The Council leverages the credibility and perspectives of Black American researchers and research partners to facilitate more relevant, community-engaged, high-impact, actionable solutions that positively impact Black communities. I am also the core manager of the Solutions to Diabetes in Black Americans core at Washington University's Center for Diabetes and Translation Research. As a disparities core, we provide methodological and content expertise to develop innovative approaches that advance the field of diabetes research in Black Americans. Today's session will discuss weight control in Black Americans with a focus on Black men. Heart disease, cancer, and diabetes are leading causes of death for Black men that have been linked with obesity and obesogenic behaviors such as unhealthy eating, sugar-sweetened beverage consumption, sedentary behavior, and physical inactivity. Strategies to address obesity among Black Americans regularly enroll more women than men, and few rigorously designed studies have identified healthy strategies to promote weight management, control, or loss in Black men. During this webinar, our speaker will describe some of the challenges with how health researchers and practitioners frame Black men's chronic disease risk, motivate Black men to engage in healthier behavior, and implement interventions to address obesity, diabetes, and related health issues. He will discuss some promising qualitative, quantitative, and intervention research and lessons learned that suggest new strategies to promote healthy weight loss among Black men. Our respected speaker today is Derek M. Griffith. Dr. Griffith is a leading social scientist focused on social influences on men's health and racial and ethnic health disparities. He primarily focuses on identifying and addressing psychosocial, cultural, and environmental determinants of African Americans' men's health and well-being. Funded by several institutes within the National Institutes of Health and foundations such as the American Cancer Society and the W.K. Kellogg Foundation, Dr. Griffith specializes in informing, developing, and testing interventions to improve African American men's lifestyle behaviors and chronic disease risk, morbidity and mortality, including reducing obesity and increasing healthy eating, physical activity, and screening, often using a community-based participatory research approach. His research has been featured in such news outlets as MSN, NPR, Time Magazine, U.S. News and World Report, and USA Today. I'd like to now invite Dr. Griffith to open our presentation this afternoon.
Let me begin again by saying thank you to you, Dr. Watts, as well as Dr. Kumanika, for inviting me to participate in this and to lead this webinar to talk largely about our work here in the Center for Research on Men's Health here at Vanderbilt University. Let me also begin by acknowledging not only the staff of the Center for Research on Men's Health, but our funders. Let me see. I think there's a little lag. Um, I'll talk specifically about some of the projects that we've had funded by the American Cancer Society that's really on cancer prevention and control, some of the formative work that also is funded by NIH and some foundations. Okay, there we go. All right. So just to give you a bit of a roadmap, I'm going to cover basically 3 key points. One is going to be talking about the context in which we're thinking about weight control in Black men, and make the argument that more attention should be paid to men's health, and particularly Black men's health, particularly as it relates to obesity, chronic disease risk, and obesogenic behaviors. The second is to talk about some of the challenges that we have and how we frame and particularly motivate men in general, and particularly Black men, to prioritize how we focus on our health, and that we've largely been unsuccessful in doing this, and I'll get into some of the reasons why I don't think we've been as successful as we could have been. And the third part is to think about and talk about what does this mean, or what are the implications of what we're describing for interventions, and that's largely going to talk about some of the formative work that we've done to look at qualitatively how Black men think about the way they define health, the determinants of their eating and physical activity practices, how they understand sources of stress and determinants of stress, and how they think about stress, and how those are implications for creating more effective interventions for this population. Okay. So first question, of course, is why should we pay more attention to Black men's health? And what I'll start with is just this idea that these aren't new. The idea that Black men's health has been poor is not really a new concept, but it's not something, it's kind of what a colleague of mine, Marina Bruce, has described as kind of hidden in plain sight. And this quote I just thought was really helpful as a starting point to think about these kinds of issues, that it's not what you look at that matters, it's what you see. And so the fact that we've been looking at data by race and sex for a number of years, yet we've kind of ignored substantively this population is a particular problem. Just to show as a foundation, and I could show you different levels of education, it would basically show you the same pattern that we've known for decades, that men, make more than women in terms of their mean income and earnings. But we've also known that despite those advantages, and usually more money and having more of those kinds of financial resources tends to lead to better outcomes. But we know that for some reason, we have seen that historically and currently, the life expectancy for males has been certainly below that of females since we've had these data. We can also look at this by within racial and ethnic groups, and this is just looking at by race. And what's interesting here is, of course, 2 things. One is it's, of course, making the case that we've already seen for a number of years that the health of Americans has improved significantly over the last century plus. But what's also striking here is that if you look at where we've seen, you've seen some closing, if you look at this in this long view of the racial disparities in life expectancy. But what you've also see is the emergence of gender differences or sex differences in life expectancy. So where the gaps between men and women within whites and within Blacks in 1900 was very small, it's grown over the century plus since then. And so the question is, how do we understand that, and why has that happened? Part of the other question or issue that I'm raising is that when we've looked at these differences in the past, we tend to be very comfortable with this idea that Racial, educational, and socioeconomic disparities more broadly are the result of social and environmental inequities, where people live, how they access foods, the economic resources, segregation, and so forth. When we talk about the differences in life expectancy or even health outcomes between men and women, we tend to take a very different tact, and we tend to focus much more on men's misbehavior or blame it essentially on men. And so part of this is questioning, well, why is it that we tend to be okay with and tend to be very focused on social and environmental factors and social and structural factors when it comes to explaining racial and economic differences, but when it comes to gender differences, we tend to primarily reduce this to behavior, attitudes, and interpersonal factors. We also know that this is particularly true of, we know that obesity rates are certainly higher in women than men. The rates for Hispanic men have now surpassed that of Black men. What's important here is certainly one that, of course, non-Hispanic Black men's rates are particularly high, certainly relative to their white counterparts. But it's also worth noting, unfortunately I didn't include it here, that a lot of this is trying to really understand how these rates have continued to rise over time. So over the last decade or so, we've seen the rates of obesity for women largely stagnate and kind of plateau, if you will. The rates for men, and particularly both non-Hispanic Black men as well as Hispanic men, have tended to continue to rise, however slowly, but they're continuing to sort of tick up. And so the question is, what's going on that these kinds of issues are still continuing to emerge and diverge? So some of the work that I've done is trying to really understand how do we explain this. And so does this idea of being hidden in plain sight. I talked about in a recent paper that was basically making the argument that part of the reason that we've had such difficulty focusing on Black men in particular, I used them as a concrete example in the context of this paper, is that we've tended to, most of the research that's looked at particularly behavioral interventions or lifestyle interventions for African Americans have really either not dealt with gender very explicitly and directly, or been considered implicitly more gender neutral, and therefore have not really attended to those kinds of issues. And a lot of the men's health work has tended to homogenize men or tended to really just focus on white males, and particularly middle-class white males. And that part of the problem is that that's kind of created this gap between men of color are sort of at the margins of the intervention research as it relates to health disparities work, and at the margins as it relates to thinking about men's health research. And so if we're going to be successful in trying to better understand how and where to intervene with Black men in particular, we have to move from just looking at that kind of an anomaly or sort of a side sort of focus or an additional variable in our context to centering the focus on them and highlighting them more specifically. And that's kind of what we're trying to do here in the center that I direct. One of the things, I'm just using body and soul as a particular example of this, is that we've also known that most of the time when we do interventions for African American populations around eating, physical activity, weight management, weight control, even weight loss, that those interventions, if we just kind of present it to the African American community, there tends to be a disproportionate rate of participation by women relative to men. Body and soul is just kind of an example of that. But we've known this for a long time. We just haven't really centered this in the conversation of, well, what is it about these interventions that tends to be more successful, more effective at engaging and therefore affecting potentially women more than men? It's not necessarily that men who participate are not benefiting from it, but why is it that we're not getting men to participate in these interventions at the same rate that we do women? And so one of the things we tried to do, actually funded in part by or inspired and led by and organized by Acorn in their previous iteration, was doing. We were fortunate to participate in the special issue that Acorn funded a few years ago in obesity reviews, and I was part of the team that did the systematic review looking at these kinds of outcomes and interventions as it relates to African American men. And essentially, what we found is there were very few interventions. I think there were 13 total. There were 7 large clinical trials that had included and presented data separately for African American men, and that was kind of the inclusion criteria, is that they had to present the data separately for African American men. We know that most of the times when we present data in tables related to interventions, we present it by gender and we present it separately by race or ethnicity, but we don't tend to cross the two. So you're able to look at how African American men differ from African American women, or how men differ from women within any particular racial ethnic group. And so that's an important limitation to our ability to really understand these issues. And so we were surprised. There were, again, those 7 interventions that were sort of the larger, more rigorously done behavioral interventions that African American men had participated in and benefited essentially equally from. But the interventions, there were 6 of them that were community-based that at that point, there were 6 of them. I think there's been some that have been published since then that were community-based that largely were single arm, not randomized, sort of pre-post designs. So they were not essentially rigorously designed studies. So there had not been, or have not been published, at least. There's some that are in the field now that are rigorously designed weight control interventions that are out there, or interventions that will look at weight control. But there really aren't that many strategies, or that we've seen, that are rigorously designed intervention strategies or trials that have focused specifically on African American men, so that we can better understand how we need to engage men or reach out to men to do more effectively that kind of work. Thankfully, the Council on Black Health, in this group in particular, has hosted previous webinars led by some folks from Project Brotherhood, Gramercy Research Group, and the like, the Active and Healthy Brotherhood project that Militia Whitglover is leading, and that Marcus Murray from Project Brotherhood, I think, provided a lot of strong insight into how we may do more effectively recruit African American men. And so I'll sort of defer to that, or refer you to that resource to look at how to recruit. I'm sort of not going to focus on that here because that's already been done well. But what I do want to focus on is more thinking about systematically, how do we approach engaging men or reaching men more effectively and increasing the salience of messages to men in the context of this type of work. So my next big question in this is, how do we motivate men to be healthier? And how do we sort of think about these types of motivations or messages? And this is largely looking at things like marketing and health communications. Excuse me. So if you look at just, there was an ad that was, a series that was out a few years ago. Sorry, this is not coming across terribly clear. But it was a series that the Agency for Healthcare Research and Quality did a few years ago to try to improve screening of men, particularly around, this is still at the time when they were promoting prostate cancer screening, to get preventive tests, to basically just go to the doctor for preventive screening, annual visits, and so forth. And as you can see from the message, you know, the idea was that thousands of men will die simply from stubbornness. And so it goes back to kind of the idea that I was talking about earlier, which is the location of the problem in terms of African American men. It tends to be within men. It tends to be not that they have, you know, lower rates of employment, and that leads to lower rates of employment-based insurance, you know, differential access to insurance, living in food deserts. It didn't talk about any of those kinds of things. It focused on this idea that the problem with men in terms of engaging and going to um, getting these kinds of screening was really inherently in men and men's attitudes and beliefs about these things. The other thing we tend to do, and that's consistent with this, is essentially attack men or attack their masculinity when we're trying to motivate men to engage in healthier behavior. So these next couple of ads are from a Real Weight Watchers series of ads. So you have this idea of eat like a man. You have portion sizes or types of food like red meat and large portions of protein that we consider sort of man food. You have TV shows, of course, dedicated to this, like Man versus Food and so forth, where you have this idea and you have these things about how we market issues to men that really focus on either reinforcing these ideas about masculinity as it relates to food, or we do things like have to sort of try to co-opt or attack men in this way of thinking about what do these kinds of issues mean. And we know Charles Barkley here, um, was the face of Weight Watchers, at least for a period of time. We know he's no longer doing that and kind of rebounded, as a lot of folks will when they're doing this kind of work. But it's still this idea that largely in our culture, when we're thinking about trying to get men to engage in healthier behavior, whether it's screening, whether it's going to the doctor, whether it's engaging in these types of healthier lifestyle behaviors, we tend to say, well, it's not the problem of the intervention, it's not the problem of the design, the theory, the concepts behind it, the location, the setting, the delivery, the mode of delivery for it. It's just that men don't want to participate. And if you look at some of the other papers that were in the special issue that Acorn funded in 2014 in obesity reviews, you'll see some of those larger issues that, again, if you look in the tables that show which studies were actually being reviewed in these series of systematic reviews, you'll see this pattern that men were disproportionately not in those samples. And so the question is, what do we need to do differently? And so the next question is that we're sort of thinking about is, given this context that I've described, what do we need to do differently? How do we need to approach men differently in this work? And so what I'm largely going to turn to is first a story, and then turn to some of the work that we've done to kind of look at this qualitatively as well as conceptually by pulling in different concepts from different spaces and theories. So, of course, now that's taking all this information and the context that I've described to how do we help ourselves as interventionists think differently about how Black men think about health, eating, physical activity, and stress by looking at it through the lens of how Black men talk about these issues. And so one of the places to start seems like it's unusually basic, but it's really thinking about this idea of what does health mean to Black men and to men in general. Well, one of the things we know is from research that was actually done more in the UK, men in general tend to, when you go to the doctor in the public health and medical field, let me start there, that we tend to think about health really from the standpoint of a fancy term is visceral embodiment, but it's basically the test that you get when you go to the doctor. So what is your A1C level? What is your blood pressure? Are you, with all the limitations of BMI now, but, we look at BMI as a measure, or body fat, however more rigorously defined and measured, what did those things say about whether or not you're healthy or not? And we know that health has been defined much more broadly for a number of years and a number of decades, but we tend to reduce it to this idea that we really need to focus on sharing information about, how you're doing as it relates to these particular tests and measures. But when you talk to men about, well, what health means to them, or when you ask them to define health, you tend to get these other things about a broader sense or a more global sense, more consistent with the WHO definition of, they talk about how they feel more generally. Do I feel okay? Do I feel good? And you get these kind of more generic gestalt sort of versions of how they would tend to feel. You also tend to get a more pragmatic sense of healthy to me means my ability to do things that I care about. So healthy to me means being able to fulfill different roles, responsibilities, do things that are important to me. So one of the things we know for middle-aged men that with all the changes that have occurred in sort of how we think about gender and some of the advances and being more progressive in how we think about gender in our society, there still is this idea that men, particularly men of color, are often defined by their role as being a financial provider or contributing financially to a household, whether or not they're fulfilling their role as a father, not just financially, but being an active and engaged father, if they have children, or even if they are just acting in that fatherly role for um, whether they're fictive kin or just relatives and so forth, being able to be a successful worker, employee, and fulfill all these other kinds of roles. But when you talk to men, that's how they really think about and define health. And that's fundamentally inconsistent with a lot of times the messages that they're getting from health professionals and even behavioral interventions that tend to define health. Well, be healthy because it's good for you. Be healthy because you may die in 10 years earlier. Be healthy because you may develop advanced diabetes and it may, cause you to lose a limb or something like that. But it's something that has to do with the health as opposed to getting to moving more to where men are and how they're thinking about these issues in terms of what does this mean for me in my daily life experience and so forth. And so the more that we can move the conversation in that direction, the better. One of the stories I tend to use to illustrate this point is the story of John Henry. And so I won't belabor this because many people tend to be pretty familiar with this story, but it's a useful analogy for how we think about um, men and men's health, or how men tend to think about, they think about their bodies and health more generally. So John Henry was known as the steel driving man, known to be very physically strong, one of the strongest men to have lived, and certainly in the space where he was. His job was to primarily be worked on the railroad and trying to bore a hole through a mountain. And it was kind of this race of man versus machine. In some versions of the story, he was a father and married, and his wife and son were actually watching this challenge that he participated in to see who could bore a hole through the mountain faster. And therefore, did they need to basically shift the economy from basically having these kinds of physical workers to just machines and so forth. So we know from the story that um, yay, he won. He beat the steam engine in terms of boring the hole through the mountain, but he also dropped dead on the tracks right after this actually happened. And as morbid of a story as this is, it kind of speaks to this fundamental issue that his strategy for dealing with health was really to think about, and this is kind of the principle behind John Henryism as a measure of active coping, but John Henryism in the way that Sherman James sort of conceptualized and operationalized it is a little different than what I'm describing here. This gets more into John Henry, the story of how men are sort of prioritizing and thinking about their bodies and health. It leads to the active coping, which is the measure of John Henryism, but it's a little different in that this is talking about how do men think about how they prioritize what health means to them. Did he think about, if we're sort of getting in the head of John Henry, he focused much more on his professional success than his own health. He decided that it was more important for him to be successful in this given sort of area of life than it was for him to necessarily take care of his own health and do something, take breaks, do whatever it was he needed to do to try to focus and deal with his own health more so than be successful in this professional challenge. And so it's useful in community sort of spaces or even in just helping us as professionals to think about if this is the way that men tend to operate, that we tend to prioritize, or some men tend to prioritize their physical, their bodies, or treat their bodies as though they're going to be fine, they're going to exist. There's a kind of an afterthought idea that your bodies you don't need to really pay attention to them, that as long as I feel fine, that I'm going to be okay. that those are the kinds of things that we've seen that we've sort of unfortunately framed as, well, that's why men don't want to go to the doctor. Men don't care about their health. Men don't care about these kinds of issues. And I think that's really just that men are focused on other things more so than they are their own health. And so part of that story is thinking also about, if health is only one of the things that men are trying to prioritize in the context of their lives and work. And in the health fields, we've tended to prioritize or think that people are prioritizing health above everything else. But in reality, men aren't really judged in society for being healthy or not. They're judged by these other things, whether or not they're active and significant in their households, whether or not they're active and important in their communities. What are they seen as people in terms of integrity and their spiritual lives and so forth, their relationships with others. So we judge men very differently than how we tend to think about and operationalize these things as it relates to health. The other thing related to this is that maintaining health is not really in most people's lives. Even this is true for women, and we haven't really operationalized this in terms of women's health research either, that being healthy is thought of as sort of the penultimate goal, but it's really something that comes after meeting competing goals. Think of hierarchy of needs and so forth, but people are very willing to, men and women alike, sacrifice their income, their health for things that matter to them, whether it's children, being a good worker, spouse, partner, providing for their families and so forth. And we tend to see that societally as a good thing. From the health field, we see that as a bad thing. And so we have these competing demands and priorities. And when we talk to men, they sort of see this in this very instrumental way, that health is really much more about what my body can do and whether or not I can do things that I care about than the ways that we've defined them in a lot of cases, interventions, or the way that we've tried to motivate men to be healthier, by saying to them, oh, you should focus more on your health because it's good for you, as opposed to, these kinds of definitions and quotes where men are talking about health to me as being able to have the energy to basically be able to work 8 to 10 hours at work and then come home and actually not just collapse on the couch, but being able to have enough energy to focus and be an active participant in the household with his family. So if we were to reshape messages from this standpoint, we may be more successful at engaging men and thinking about the ways that we frame a lot of the interventions, the ways that we focus a lot of even if you think about the theories behind a lot of the interventions, they tend to take a very pragmatic sort of direct look at health from this standpoint, as opposed to centering health in the lives of the participants that we're trying to really engage. And so part of the other component of this is considering how men think about what it means to be a Black man. And so to do this briefly, I want to just talk about some terminology that tends to get a little used a little loosely and imprecisely. So masculinity, although, for more than a decade or so, people have been talking about masculinity in a plural sense, that it reflects more a heterogeneity and diversity of ideals about what it means to be a man, what it means to be a biological male and an adult, and that those things should be something that cut across settings, populations, and so forth. But it's usually seen as this sort of singular notion, masculinity in a singular sense, that we tend to reduce it to within a U.S. context. We tend to think of masculinity in a very singular way and think of it not in terms of a gender sort of norm, a structural force or factor, a cultural sort of belief and value, but as something that is internalized and processed and measured or thought of as really reflecting internal sort of attitudes and beliefs and ideals that men have within themselves, absent the context or independent of the context in which it's actually occurring. And part of the problem with that is that masculinity tends to really be dependent on the context in which it's being shaped and the body and sort of how that gets sort of represented and experienced in men's lives. And so that moves the conversation away from understanding masculinity. Um, Again, it kind of gives this very flat, simplistic notion of what masculinity is, and really tends to reduce it to something that is really more of an internal factor and force, like we saw with the idea that um, that men die from stubbornness, not that men die from their social experience of being Black males, and that those kinds of things are really important to reconsider. The other thing that's different about masculinity versus masculinities plural is masculinity as a singular notion doesn't tend to take into account that the ways that men think about their gender identity and think about what it means to be a man, that those things hopefully change over time. Um, that a lot of the ways that we tend to operationalize things across groups, we've tended to see notions of like machismo, or that men just are tough and rough and whatever, as something that we see as a universal sort of thing. And we don't tend to think about, even if we believe that, how those things are different across different age groups and populations. And it's important to kind of do that. It's important to realize that in middle age, that you have this idea that those kinds of tough, rough, not focusing on weakness, taking risks and so forth, can be the ways that men will adapt these lessons that they learned when they were younger to, let me just focus on, and have kind of tunnel vision with work, with focusing on work. If I'm depressed, then I'll just put my energy into work. I'll just put my energy into things that are going to be the reasons that I'll be judged by other people in my life, um, such as the kinds of priorities that I have, the ways that I'm being successful in um, providing for my family or contributing financially to my household and so forth. And that those kinds of things can lead men to have these issues like midlife crises and so forth. The other thing is that as men age, you have, um, a lot of the ways that we think about masculinity tends to have something to do with the physical body, the way that the body can actually do things, and you tend not to have to think about or worry about whether or not the body is able to do certain things. And we tend to realize that as we age, that those physical skills tend to decline, but masculinity doesn't really take those kinds of things into account. So I'm going to skip over that for now. One of the things I wanted to highlight as we sort of move towards sort of closing is the idea that, within these kinds of gender sort of things, it's not just that I'm thinking about these things in terms of how men see themselves, but these kinds of phases of life, if you will, or developmental stages of adult development do matter and do have implications for how we think about who's at most risk. We tend to think about, as people age, that their risk or health profile tends to be worse as they age, but we know that actually obesity tends to be highest among men who are middle age. And we know that for African Americans, actually, from the work that David Satcher and his team did more than a decade ago, that the group that had the highest risk and that was driving really the black-white gap overall in excess deaths were really middle-aged men. It was men who were, it was actually a more narrow age group than 35 and older. I think it was the 45 to 54-year-old age group. Parenthetically, we've seen this particular age group get a lot of attention recently with into things like diseases of despair and so forth. And it's that same age group that we've seen with white males that have really garnered a lot of attention. But the question is, we've known that Black men have had these issues with this age group for a while, and their health has been, typically worse for a long time. But we've tended to not really focus on that. In the interest of time, I'm going to kind of skip some of these ideas of sort of getting into the concepts of manhood to really get into just briefly some of the more concrete things that we've looked at in some of the work to really understand and unpack the way that we think about Black men and masculinity and manhood, and some of the other issues specific to eating, physical activity, and stress management. I do want to pause here to say that one of the things that we thought about or we found when we sort of looked at how men thought about this idea of what manhood means, which is kind of these gendered ideals and how being an adult male is different than just being male in and of itself, that both manhood and health really were about embodying certain characteristics. Again, we sort of talked about this idea of being health is part of embodying these characteristics, being able to be independent, supportive of others, and so forth. It also, both manhood and health have ideals of what you can do or what your body can do. So again, health being that your body you can do sort of 8 to 10 hours of labor, and it's not an accident that they focus on your body being able to do things like work, because that tends to be one of the things that we use to define whether or not men are successful in their general lives. The last part being how you seek to affect others, and that health and manhood are both relational concepts, meaning that they're significant in not just in and of themselves for men in their bodies, absent the social context in which they live, but being healthy is something that you're supposed to use to affect other people, to do other things, and that manhood is also something that we see as a foundational set of characteristics and identities that really influence, or that are supposed to be cores to how men influence others. And it's really in relation to how men sort of are relating to other people and other groups and how they're influencing others. So I want to get quickly to, in the last about 5 minutes or so, just highlight some of the things that we found sort of qualitatively. And I'm going to sort of walk through a couple of slides each on eating, physical activity, and then stress management. And our work really began with this. My work in this area really began with a mentor research scholar grant from the American Cancer Society that we called colloquially sort of Men for Health. That was really a qualitative look at adapting the body and soul intervention for African American men. So one component of that was, how do we take the core assumptions and components of body and soul that I mentioned earlier and take those sort of components and see, well, what are the assumptions about where it was? So the fact that it was done in churches, was that the right and appropriate setting for this particular intervention? The physical activity, the eating intervention, and the education was done with, there was some small group activity that happened within those particular groups. How did that sort of fare and function? There was also sort of complementary thing that Dr. Resnicow had done at that time called Healthy Body, Healthy Spirit, that also incorporated physical activity. And those included, promoting group-based physical activity at that time. It was aerobics and so forth, and they would give them gospel music tapes for them to do aerobics to. And so was that really the appropriate strategy for promoting physical activity? So the goal of the career award was basically to kind of try to explore these basic issues. So what we found in a series of papers, and then in a subsequent, these were focus groups that we did largely through that career award, and then subsequently did individual interviews to refine further how we understood these perspectives of Black men. But we looked at things like how men's eating behaviors was so much interdependent with the women in their lives. So a lot of the men that we talked with were middle-aged and older, and they talked about how their wives really shaped their eating behaviors, both at home and even when they went out. Well, most of the behavioral interventions around eating tend to really focus on the individual, not on their family context that's shaping what they're actually eating, the food choices, food preparation, and so forth. And while we know that African American men, relative to some other groups, tend to do more in terms of household food preparation and so forth, it's really best understood in the social context of their families and in the women in their lives. And so this paper was really just about how men thought about that role. This next paper was really about how men thought about what meals meant. And the title, the subtitle, "I'm ready to eat and just grab whatever I can get," came from how men talked about approaching lunch in particular, and that lunch was something to just grab and to avoid hunger. It really wasn't focused on the health of things. It was really focused on convenience and preferences and what I could do, to eat with one hand, drive with the other, and get somewhere back and forth to work during the time that they had available. So it's a very different context to thinking about how they defined what were priorities as it related to eating and how we needed to do that. We also know from this work and others that a lot of men in this population tended to skip breakfast. When we asked them about what a meal meant, they tended to think of dinner and primarily Sunday dinner. So we literally had to prompt them in this focus group to describe other contexts for eating that were not dinner, which was the meal that they thought was most interdependent with their spouses and women in their lives. And so, one strategy potentially for thinking about Black men and eating would be to think about, just getting them to focus on the meals or on the eating practices where they are primarily making choices for themselves or more likely to be making choices for themselves, namely breakfast and lunch. Some of the other things that we found, I'll just quickly sort of mention. I know we're at time. Their preferences in terms of that we found that there were differences in how men thought about or viewed the world based on whether or not they were actually eating recommended levels of fruits and vegetables or not. And they saw their environment very differently that based on those particular ways of seeing. And so there were things in there that we can incorporate in interventions where the men who were actually more successful at eating healthier didn't see quite the barriers. They saw sort of more opportunities, whereas the men who were sort of low healthy eating, if you will, saw more barriers than they did, and really sort of had a struggle to think about how they were actually going to overcome these particular strategies. So it really spoke to that there were concrete things, cognitive things that we could actually focus on as we thought about the larger context in which men were making these choices. When it came to physical activity, one of the things we found was that role strain, and these, I was talking about this, in slightly different language earlier, but these idea of gender roles and responsibilities were what men described as the primary barrier to them being more physically active. It wasn't about access and food choices and I'm sorry, access and environmental choices, but they actually internalized this idea that they should be able to overcome these environmental barriers that may actually be quite real for them, that they're not really seeing as important in that particular context. Um, you may notice that in a lot of these perspectives, that in a lot of this qualitative work, we've looked at both men's perspectives and that of women in their lives. And the reason for that is because men's health and health behaviors tend to be more interdependent with women in their lives than women's health and behavior is with men. We also know that women, it's called shadow data, where women's perspectives tend to lend something to how men understand and what they actually do as it relates to health in a way that's very insightful. So we've done that from the beginning, where we tried to capture women's perspectives in addition to men. So we've done a couple of formative interventions. We looked at a variety of factors that shaped how men thought about stress and how they defined stress. And again, looking at from both men's and women's perspectives. We're currently in the field with two particular intervention strategies. One is a faith-based weight loss intervention that we're doing in Atlanta right now in churches. So we actually moved away from churches, or the original proposal was to take what had been done in Body and Soul and see if we could do it in fraternities and lodges. And we ended up returning to churches because they were more, the culture of the church was much more health promoting than what we were finding of a lot of fraternities and lodges. And those organizations tended to also be ones that tended to support, meet frequently enough to provide the social support that was required. We also have part of the U50 Forum Precision Medicine, another study that's looking at Black men and Latino men in physical activity and eating. The last part I wanted to say as it relates to this is we've tended to use self-determination theory to drive this. You'll see part of what you'll see in the narrative that I was just trying to lay out was that a lot of this, even though there are a lot of structural factors and forces, that men tend to operationalize and define things as though they actually have more control potentially over these environmental forces than they may actually have. But it's important also to think about what are the sources of motivation for men to actually engage in these healthier behaviors. So we're trying to utilize what we've learned about notions of manhood and combine them with some of the ways that we're finding that men think about these kinds of issues to really inform strategies to improve the intervention and to improve the work that we're doing and the salience of the messages. So the components of the Mighty Men intervention that we're doing now is that we have these individually tailored goals and messages. We have small groups and small group personal training that the groups get, as well as having them wear Fitbits and get some web-based resources and information about what they're doing. And I will just stop there. So thank you.
Thank you so much, Dr. Griffith, for your very interesting presentation on some of the issues affecting Black men around their health and accessibility to some of the different ways in which we might be able to support their health throughout the lifespan. I'd like to open the floor now to any questions that our audience may have. And just remember, we do have the Q&A function, so if you wouldn't mind typing in your questions, we can pose them. We have about 5 more minutes, so we do have time to take a few questions before we close out the webinar this afternoon. And while we wait to see if there are any questions coming in, I was wondering, I know you had to kind of move quickly through that last set of slides that you had, but can you talk about some of the implications of the work that you've done up to now as it relates to recruitment and retention of Black men, potentially in clinical trials around lifestyle and behavior changes? And I'm really thinking about how you potentially tailor interventions to address these concepts of masculinity and manhood and perceptions of health for heterosexual Black men.
So yeah, thank you for the question. I think some of the ways that we've incorporated into a lot of these issues has been framing the interventions more in terms of what's the goal that they're sort of aspiring to achieve. So, you know, being healthy not just for the sake of being healthy, but being healthy because you want to achieve some larger goal or aim or something like that. And so I think that's kind of been the bigger narrative and theme that we've tried to see if that's going to be a more effective way of engaging men and keeping them engaged. And we'll see, you know, how successful we're being. We're, like I said, in the field now in the early stages of the current intervention, Mighty Men. We're going into the field with the U54 one in the fall. So we'll see how these work. But that's really been kind of the biggest ways that we've shifted the kind of attention, and then trying to, in some of the educational components, bring in some of these notions of helping men to realize, you know, how much some of the things that they're trying to do well in their lives, like be good fathers, providers, contribute financially to a household and so forth, those good things can actually be the barriers to them actually engaging in healthier behavior. So it's not really a choice of being healthy versus doing these things that are good, but it's finding a way to do both of them. And so it's trying not to sort of get this sort of dichotomous thinking, but trying to get them to think in a more nuanced way that they've got to make both sets of choices, not sort of one or the other.
Definitely, that they're all interconnected.
Yes.
And I'm just wondering, this may be tangential to, you know, your discussion today, but I'm just thinking about, you know, kind of distrust in the Black community for research and to some extent for healthcare practitioners. Have you touched on that at all in terms of looking at some of the characteristic ways or reasons why Black men have kind of, you know, not participated in research trials or may not be, seeking the type of healthcare or addressing some of the issues that they may have in terms of their personal health?
Ironically, actually, one of the next projects that we're doing is looking at Black men and their trust in healthcare, and how we may better understand that to both measure it as well as to try to facilitate exactly what you're describing. And part of the argument that we made in the application to get this funded was basically that some of the measures, most of the measures that we have out there around trust probably are not sensitive enough to get at some of the issues that you're describing as it relates to the unique experience and history of particularly Black men. And so both from a gender standpoint as well as from a racial and ethnic standpoint. So, so yes, we haven't sort of brought that into this work in terms of the behavioral intervention side of things, but we are sort of thinking about that in relation to sort of larger health promotion. I think there was a second part to your question, though.
No, it's I think you pretty much covered. I was just thinking about it from the perspective of kind of the historical and cultural opposition to some aspects of the healthcare system, as well as
Oh,
research that might impact the Black community and how that potentially um, affects whether or not Black men are participating in clinical trials, are seeking opportunities to interact with physicians or healthcare practitioners to support their health.
yeah. So to that, we actually, as part of some of the focus groups that I was describing, we actually did ask questions and do a paper about why Black men say they don't go to the doctor. And what we found was a lot of them talked about that essentially um, it wasn't a positive experience. It wasn't beneficial, that they weren't getting information, resources that they otherwise didn't get. They were getting a lot of lifestyle advice that really wasn't followed up with resources to be able to implement that advice, or it wasn't consistent with the resources that they had in their lives. So it ended up being a very pragmatic sort of way of approaching this, and it wasn't about sort of the historical context or even the cultural context or mistrust. It was really about their personal experiences and whether or not they were benefiting. And from taking off time from work, from taking away time from family, whether or not the messages that physicians and healthcare providers were giving them were consistent with people that they did know and trust. So if I trust my mother who's had diabetes and I develop, or I'm pre-diabetic and I go to the doctor and what the physician is telling me is inconsistent with what my mother said, I'm going to more likely listen to my mother paradoxically than I am to the healthcare provider, because I know she cares about me and has my best interest at heart, unless the doctor actually engages what she says and corrects any misinformation that she has. But they actually gained credibility. The physicians gained credibility by saying things and addressing things that were consistent with loved ones. So there are those kind of practical things that are not necessarily just about the larger historical cultural experience in general.
It's certainly about the social experience and the person's lived experience.
Absolutely.
Right. Well, I'd like to thank you, Dr. Griffith, for sharing with us today. I'd like to thank you for the perspective that you've provided as it relates to this very interesting topic, especially in terms of Black men. And I'd like to thank you all for participating in the Solutions to Diabetes in Black Americans webinar, Weight Control in Black Men, Context, Challenges, and Intervention Considerations. We will be emailing a follow-up evaluation survey and share video of this webinar shortly. And if there were any questions that were not answered today, I will forward those to Dr. Griffith, and we'll definitely have a venue to share his response. So thank you so much.
Thank you.